Hi, Dr. Goel, welcome.
Yeah, thank you. So I think I'll ask Roopali to describe you the case. Can Roopali, you?
Yes, sir.
Can
Good afternoon,
we
everyone.
see the slide
So
or?
he's a 79-year-old gentleman. He's diabetic and hypertensive. His follow-up case of LED stenting in 2008 for unstable angina was done. He did well for 10 years, and he presented us with non-STMI in November 2018. ECG showed global ST depressions in V1 to V6, and we did his angiogram, which showed left main disease or ostial, and followed by severe disease at the left main, and LCX was normal, and RCA was proximal total occlusion. We did the procedure of left main.
Can we see the
Can we see the
angiogram?
angio, please?
Can we see the angiogram, please?
Not yet.
Yeah. So that was the angiogram that he presented with. So we have severe left main disease. RCA
Next.
was probably occluded in 2008 also, and LED was done that time. So now this was the
Next.
disease. So at that stage, we considered that we will probably do the left main and do RCA second stage. I think the RCA, we are not sure whether it was because it was done outside.
Outside, sir, at that time, sir. And we
So
did a
we are-
MIBI scan for that to confirm that whether stress-induced ischemia is there. And MIBI scan came positive for a stress-induced ischemia in the RCA territory. So
So
can we go next?
this was done after we did the left main angioplasty. Because
Yeah, there is an issue doing the left main before the RCA when you maybe could do the RCA antegrade because it's a higher risk procedure.
Agreed, but the issue is the culprit was in the left main because RCA, if I'm not wrong, he had an inferior MI some time back. And the angiogram was not available to know that RCA was blocked. But the operator did a LAD in 2008 outside. So I feel the RCA was probably occluded that time also maybe. And the culprit was in the left main. And having done the left main, his unstable angina and everything settled. And then we had a thought, should we leave him like this? But then we did the MIBI scan, and the MIBI scan showed reversible ischemia in the RCA territory, although symptomatically he is much better, as I can tell you. And this was the final result that we obtained on the left main, which was done about 2 months.
In November 2018, sir.
Yeah, it was done about in
6 months back.
5 months back. And that was the final result. And so now he is here with us for the RCA second stage with a view to complete revascularization, you might say it like that, with the viable territory in RCA territory and some reversible ischemia documented. So what are your thoughts or whatever? That's the patient.
Yeah, well, now you show us the bilateral setup shot.
Yeah, so now
Your
this is the setup shot. Yes.
Femoral, radial,
Well,
combined?
we have one radial and one femoral. I always like to do the main artery, the culprit artery with the radial, and we use the femoral for the contralateral approach. So we have a 7 French EBU guide in the left coronary, which is the feeder artery, and we have Amplad's AL1 in the right. So, and that is the picture, and there's a lot of bridging collaterals which are filling it antegrade. As you can see, there's a mesh of bridging collaterals. The distal artery size is good, and we do have some good collateral from the left. But the only thing is we have a stent in the left main. So although the collateral is pretty good, as you see, so as a primary procedure, I'm not very keen to take up that collateral. There is some little pressure damping, as you see in the green channel on the pressures.
Can we see the REO, the LAO projection of the right?
LAO, yeah. Can we see the LAO of the right, the lower, because we're doing it in biplane. Can we see the LAO?
A-plane?
Yeah. See, once you have homocoronary collaterals, do you still need bilateral injection?
You know, I would still want a bilateral injection because when you are working through this artery and your microcatheter and stuff devices start going down, some of these bridging collaterals start getting lost and then they occlude and then you can't see anything what's happening distally. So this is very important dictum that you should still have a contralateral injection. because that's the time you will be able to see retrograde filling better than the antegrade.
Another point is that we must always start with amplas as you did in this case.
Yeah.
Some beginner start with JL, JR, then it's
No,
actually a
no,
problem.
no, amplas
You choose
is
a
a-
good
amplas
right
is-
guiding from the beginning itself.
And we have a side hole catheter on the left, and by choice I don't take a side hole for the CTO interventions, because you know, sometimes side holes gives you a false impression of being okay, although you might be deep inside the artery.
Dr. Goel, we
Yeah.
need to proceed because
Yeah,
the other
so-
lab is
yeah,
also in a
so
critical
so now with
situation.
this, in the waiting situation, what I have done, I'll show you some fluoros are recorded. So
Of course, we
were
need
with
to
a,
see the LAO. They should
uh,
switch
you,
the video
you
to the
should
LAO.
show me the LAO. वहाँ पर उसको बोलो.
Can you show the B plane?
Always the B plane first, please. Can Mr. Vikas?
Your
Always
primary-
the B plane. The
Primary
primary
choice
plane.
is antegrade, retrograde. What's the
Well,
primary choice
primary
in this
choice
patient?
right now is antegrade.
It should
and
always
if
be
it,
antegrade in
yeah.
this situation.
Especially
Yes,
when you
as
have a
I
good
told you, because
collateral.
we have a stent in the left main
main to LED.
with some damping, so although you can do it, so but my first choice is antegrade, and the distal vessel is good. So if in case I get subintimal, I might use a stingray. That's what I had thought. So let us see. So can we move forward? So that's the first recorded fluoro. And then there's the second step. Slowly I am going down. This is, we've just done it now.
This again is a
Which wire is it?
This is
Start
a XT. I usually start with a XT in these situations. Forward, please. And don't replay it, because replay, the wire goes back again. Next, forward, please. Next fluoro. Okay. So this is further on. And then we have done some check shots. And when the check shots come, you can show the check shots. Okay, so that is how we proceeded. So we are little, and we are doing biplane. So you're seeing the LAO. Now, can I show the A plane, please? So you see the tip of the wire in relation to the artery. A plane, please. A plane, A plane, A plane, please. Mr. Vikas has to be in line. He has to switch to A plane. A plane will be RAO. B plane will be LAO. When I say A plane, please show me A plane. Okay, A plane is RAO. Because we need to see both the planes. Because I am seeing both the planes here.
Yeah,
Can
especially
we
in the
move-
right coronary, a biplane is a very big advantage.
Yes, because you don't know, you may be feeling that you're going all right in the LAO and you may be haywire in the RAO. So now, can you see the RAO?
Yeah,
So
we
I
see.
am pretty in line with that distal vessel
Yeah,
where
that
it's
looks
coming.
very good.
Yeah, so it looks okay. Now at the last point, now you switch to LAO, please. Show me LAO. And most of these procedures I do in biplane. B plane, please. Mr. Vikas, be very cognizant of it, B plane and A plane. B plane, please, immediately it becomes LAO. B plane, Mr. Vikas. Mr. Vikas, you should show the B plane. You have to be very swift in it, Mr. Vikas. Mr. Vikas, you have to switch to B plane, please. You have to switch the planes very fast. Can he switch it?
Next.
Maybe in Hindi.
telling
Maybe in Hindi. B plane, उसको बोलो B और A में switch करना है. उसको बोलो B और A में switch करना है. विकास जी,
it's better to tell the plane rather than the B plane, A plane, LAO, RAO.
LAO वो नहीं जानेगा ना. He has to, he's somehow not understanding it. सुन लो, इधर आ जाओ. Come here.
Okay,
B
why
plane
don't
or
you go
A
on telling
plane?
us what you did actually? Doesn't matter.
No, so we
Let him
are
take
here.
his time.
We are here right now. Now I'll show you the B plane only because I'm working through the LAO. I'm working through the LAO, so let's do something live.
So you advanced a little bit,
Yes,
and
yeah.
now it must be through or not through.
No, it is not yet through. That's where I am. So let us see if I can go through. If someone can focus on my hands and
We
show
are
what's happening.
still seeing A plane.
And that too
No,
still.
B plane please. LAO दिखाओ.
So
LAO दिखाओ जिस पे फ्लोरो चल रहा है. LAO दिखाइए please. about
actually, the dampening of the left
Yes,
guide
yes.
is an indication that maybe the stent is underexpanded. Did you do the procedure with IVUS
Yeah.
at that time?
That too, I felt distal part of stunt since it underexpanded. You could see dye whirling around within the stunt at distal part, not beyond the stunt I'm talking about. That I know there's
we'll
aneurysm
talk
there.
about it.
Later.
Yeah.
Now we see the B
Yeah.
plane.
Okay, so I think I am either through or subintimal. Let's see. Angio, please. We are still not reached.
It seems to be
We're
out of
still
line.
not reached. Okay.
Depends
Yeah.
on the operator's feeling, but I think you need more torque control and
Yeah, I
time
think
to
we-
switch to a
yes.
Gaia,
Yeah, that's what I
because
think
you
I'll do.
need to make the inner turn.
Yes, I think I'm trying to advance the micro a little.
So our commentators, also the approach would be an XT type wire.
Let's do a Gaia. I think I'll change it to Gaia now.
What I feel is that
let's-
in the beginning itself, we should choose Gaia in this.
No, no,
case.
no,
This is
no, no.
what I was
XT
feeling
goes
about it.
very well.
No.
No.
I think
Once you place the
Yeah,
wire, this
let's get the Gaia 2.
microcatheter.
Gaia 2, please.
I think the XT is a
To
proper
start with.
choice because you never know, there is loose tissue, these are soft lesions often, and you don't disturb too much. But if it doesn't work, you
So
need
we
to
have
switch.
we have a Gaia 2 now.
I think that was also yesterday's general message. The sequence is XT, Gaia type, and then a hard type. And then the decision is, if you are subintimal, I would choose parallel, and then retrograde. I would not choose Stingray, because Stingray causes too much of extensive dissection, and you have wonderful collaterals. It's an easy retrograde approach here, especially when you have stents in the left system. So this is the Gaia already?
That's
No.
the Gaia, yeah.
Now we get the A plane again.
B plane, please. जिसमें live चल रहा है.
Okay, B plane is there.
Angio, please.
So your photo.
No, I don't think. The Hornet is a Confianza 12. The other Hornets actually are already retracted from the European market because they were useless. There's a good fighter from Boston and the Hornet 14. You could use a fighter as in the beginning, but the Hornet 1 and 10 are already off the market.
See, as an angled microcatheter is concerned, you have to be near the lesion to angle it. Now you are much proximal to the lesion side where wire is entering into the lesion. So here is not going to help it because the distal segment is much distally. Wire microcatheter is much more proximally. Your wire is much more distally. From there you have to turn. Your catheter not yet crossed there. So you need no role of angle in this situation at this time.
Dr. Goel, did you
Yeah.
change the wire already?
Yeah, it is Gaia 2.
Okay.
Can we see?
I'm informed that we have to move to
Okay.
Hyderabad
Okay.
because of the slot,
Okay.
and
Okay.
you have very high radiation, I can tell you.
Yeah. Okay, go ahead. Go ahead. Left short,
You
please.
can work in any plane now.
Left short, please.
Dr. Goel, you are
Yeah.
back on.
Yeah, I am back
No
on.
progress, we saw.
Yeah, no progress. So, and I think it was going the wrong track. So I have left the microcatheter till the point where I was, and I have pulled back the wire, and I am now going retrograde on the from the left side.
You didn't want to try because you were very close in the outer curve. You
Yes,
could have
I-
easily done a
No,
parallel wire here.
It was very far away. I'll show you the pictures, and being so far away, I think I was almost. It looked as if I have crossed, but it was miles away. That's the last picture. So I got it back,
This is far away.
but this is far away. So there is no way that I think I
This
can.
was Gaia wire.
Yeah, that was Gaia 3.
Three.
So I think the best thing at this stage would be to do retrograde, you know, because we have good collaterals, and I'm sure we should be able to do it retrograde. Okay, so that's what I am doing now.
The only issue
So-
is the dampening.
Yeah, I know, but the systolic pressure is okay. There is no systolic dampening.
So which,
There is some ventricularization.
which
we understand.
microcatheter will
Test.
you use?
Well, I have a Corsair inside. Well, we are already
So we need
in
the A plane now.
Which plane is he
Can
showing?
you show A plane?
A plane, please.
Okay, okay.
Never. It's a nonsense technique. Sorry. Yeah. If you know how to wire, you don't need to destroy the vessel by contrast.
2 cc में contrast होगा. You want to do contrast, sir?
No, these are techniques that are useful if you want to destroy the vessel and
give
go
me a-
back with a re-entry approach. But
इसकी ज़रूरत
the
नहीं है।
approach that I would prefer, and most of
मुझे
the
give me another
operators
wire.
here,
Give me
is
another,
don't
Sion
destroy
wire.
the anatomy.
Yeah, right.
This is
We need a
something
different
for
curve now, no?
heavily
Because that had a big
calcified
curve.
lesions, but
You see,
not
the curve
in this
that
situation.
entered would be
This
different
is
from
a
the curve
simple
that
wire
will track.
approach, and he can maintain the complete anatomy by going retrograde now. How long?
How long you will try?
Which, antegrade or retrograde? No, I think
You see, individualize. You
if,
feel the vessel
if
and
you
decide
are
how you
too
are
far
relevant.
away right now, as he said, I would have thought that there was a position which was closer to the distal cap originally, and then you could have switched to parallel, but if it doesn't work, retrograde is easy. Not, we should never say easy, anything is not easy in a CTO, but the option is there, so I think that is a very feasible way to go. And if that fails, then you can always do the re-entry approach, as long as there is a good visualization distal. So Corsair and a Sion, I guess, or a Suo? Sion?
Sion.
This is a Sion.
Sion. You
I
have
need
a
a
reference
RAO
image that tells you this is the right collateral, I guess.
Yes, yes.
Because you didn't
Let
do
me
injection.
try. Let me see the RAO caudal. Can we do an injection here? Well, I'm doing the main artery injection. It's not hooked as well. I'll do the tip injection then. But I don't want
LAO,
to.
sir. LAO.
Is the septal taking off within the stent or distal to the stent?
It is taking
the
off at the within the stent. It's the distal end of the stent, but within the stent. Come on, angio, please.
Yeah, there are many options there, but this seems to be not the right branch.
Mm.
We have to go a little up and take this branch, sir.
Not connecting to the previous.
But you cannot say really. No.
No, that's not right.
Yeah, I think that's a very good comment. To have a safety wire in the LED, especially when you work through a stent there. I also personally would think, I do it regularly because my left guide always comes from the radial, so I always stabilize with a distal wire. Dr. Goel, that is
Yeah,
very
yeah.
good
Take a new wire.
advice, I think.
Yeah, I think we can do that.
Also to
Ek wire-
control your guide better with during the procedure.
Huh, we were interconnected. Introducer.
Give
So we
me
try a little bit with the wire, but if the wire doesn't go, we need to visualize. I think we should
Yeah.
Injection, tip injection.
have a selective injection at one point then. Because there are a
See
lot
the
of
first
branches.
shot, which is the best branch to enter. This doesn't seem to be that good.
It's probably the big septal, but
Take it.
Torquer, please.
Yes, sir.
Torquer, please. इसका pressure देखना है. Very tortuous LED.
The torch was
Mm.
not
I think
Yeah.
leave it
Okay,
here.
okay, okay.
all
do
the
tip
more
injection, sir?
important to have a safety there.
Let me do a tip injection. I think I'll do a tip injection here.
So that is the Corsair Pro,
No,
Yeah.
that's the
regular Corsair.
regular Corsair. Okay.
I personally
Okay.
switch completely to Caravel, I must say, for all situations. Especially going through a stent, it's much more convenient. So that doesn't seem to
It
be the
is,
right
yeah.
branch. You need to
Well,
take...
it is connecting.
Yeah, but it's very tortuous.
I think
What
there
is
is a
your projection
proximal
here?
one.
What is
this
your
is actually areocranial.
Yeah, you need
So-
to go to REO,
Caudal. Yeah.
either caudal or zero, because this doesn't show you the distal. But it's a vessel that looks like it needs a sewell.
Yeah, correct. Angio, please.
Oh yeah.
Yeah, looks
Okay.
okay.
So, but
I
that's
think
the
there is a
important point. This cranial projection is overused nowadays, and actually it's not helping in the septum. It's good to
Yeah.
get into, but then you need
Yeah,
to
that's
switch.
correct. For getting into, you need the cranial, but for exiting, the junction with the RCA is better visualized with the. Can I have a SUO3, please?
Brother, SUO3.
That's what we call
Yeah,
a CC2
O3, yeah.
collateral, actually, but still
Can
the
I get a
tortuosity
SUO3,
makes
please?
it difficult.
This one is connecting. pretty
But we
well.
have to go bend like this. Introducer?
There, you mean there is a mid-segment of the
Mid-segment,
collateral
the
that's a little bit
collateral, there
thin,
is
but
yeah.
it will dilate once the
Or to spasm
wire
or-
is passed. But it's
Please
the part where you can damage it. So that's why a suo is the less traumatic option.
How far?
It's a. You have some. Okay.
Dr. Werner, I have a question. Would you would you go with the parallel wire in this particular case, or would you first switch over to retrograde and without attempting a parallel wire, would you?
The approach is to be efficient and
Yes.
not to lose too much time in one mode. That I agree completely with our US colleagues. But parallel wiring is not losing time.
And
It's
where exactly with the Gaia series would you stop, for example, in the RCA? I mean, before switching to, say, around the bend, if it's really
You
identified it's in the false
Present at this
lumen,
point, we have to
You spend 2-3 minutes.
that's it.
I think.
That's it. Now he managed very good.
Yeah.
So first you went distal to the apex and then
Yeah.
it smoothly went around. So
So retrograde.
that was a good demonstration of the suo capability.
Yeah,
Let's-
that was SUO. That's right. The
we
SUO does it much better.
must make the point
Okay.
that it doesn't make sense to switch when important parts are going on. I think you must consider among the course directors that. So let's see how the Corsair follows, and
Okay.
because again we are asked to switch to Hyderabad,
So
Yeah.
maybe you
45
just
years.
give it a try.
Yeah,
the Corsair.
can I see the, can you show the LAO? Torker, Torker. Can I change it to Sion now?
Regular Sion?
Sion,
Roopali,
yeah. Sion back.
Okay, you already are through.
Yeah,
Very
I'm
good.
already through
So
into the
we
main, yeah.
briefly go to Corsair, to Hyderabad while you
Yeah.
set up the retrograde.
Yeah, okay.
Just tell us which will be the first choice of wire.
I think I'll initially try Sion, but I don't think it will go. Then I'll probably do Ultimate Bro 3. That's the one that I usually
Yeah, but
want.
at least the Sion is good to get more up
Yes,
because there are
yes,
side
yes.
branches.
Till I reach the
get
distal
to
cap,
the distal cap.
and
Okay.
I will explore the
So
distal cap with Sion also.
We follow you on the side screen
Yeah,
and we switch
yeah.
to Apollo.
Okay, great,
Hyderabad.
great.
So Dr. Goel, we are back with you.
Yeah, just a sec.
Right.
कौन सा
So-
वायर है?
Yes,
ये है? हैं?
Yes, sir.
So now you are faced with the problem that you need an antegrade wire position to do
Yeah.
the reverse cart.
Yes. So I'm trying to push my balloon.
Okay.
But there is not yet overlap. These wires
Yeah,
don't
yeah.
seem to be,
in
you
the
need
same
more
plane. You need to see
parallel, more overlap of the wires.
You see other view also.
So ultimate photo, I continue.
And the other plane, they look not in the same.
Um,
Ultimate.
this is the ultimate pro. I think you need to go in a little more. Where's
Even
the
in this
anti?
plane, they're not overlapping actually.
So this one, ultimate pro.
What does the A plane tell you? Because it seems to be a different course than you took with the initial. Yeah. I'm not sure whether you are in the same route that you had before.
Seems to be too far away before you started.
Actually, I better change it to a Gaia. I think I better have a Gaia wire here first. Give me a Gaia 2.
What is your retrograde wire?
Yeah, this was ultimate bro. I want to change it to a Gaia 2 now. Because if in case I do balloon and reverse cut, I will need to direct it. So give me the Gaia 2 here.
So the thing here is that
This Gaia 2?
retrograde doesn't work with without antegrade. This
Yeah.
is always the message. We can go back to B plane, I think.
Oh.
Okay. Enter, sir.
So ACT is at what level right now? Because you work through a
330,
left
yeah.
main stand.
Well, it is 3:30, I think, about.
Have we given 2000 apparent more?
We have given 2000 heparin about 10 minutes back. Yeah,
So
integrate
this is a
balloon.
different way, but maybe the right one, because I'm not sure about your antegrade wire.
Right, please.
Antegrade wire is
I
different.
think it's outside. We can put
Where is the
retrograde wire
antegrade?
more inside.
This is the antegrade wire?
Retrograde, it's a retrograde wire.
Where is the antegrade wire?
This one. Torque.
He has anti
Dot
balloon now. We want to see it.
Antegrade wire, please, come on. This is the balloon?
Yeah. Kite, sir.
So you could advance the, this is a 2 millimeter balloon without pre-dilatation, or did you do
No,
pre-dil-
no pre-dilatation. This is a 2.5 balloon.
Okay.
That is
No, they're out
going
of-
different.
okay, sir.
Where's the tip of the balloon? Is it in the true coronary proximally or you're in the collateral?
No, I'm not in the collateral. Actually, the two wires are not in the overlapping plane. That's the issue.
I think
Yeah, the thing is the antegrade. I'm a little bit suspicious when you can advance the balloon
Without-
without
yeah.
problems,
This is what I'm saying. Are you in some collateral or true lumen? That is
or
slightly difficult to say.
subintimal or outside.
This looks better, I think. Going more in
The retrograde wire seems
Retrograde wire seems
Better.
better.
better. This is
Yeah.
better.
So we can make the connection higher.
Yeah, but maybe you retract the antegrade
balloon
wire
must
and
balloon.
rewire towards the retrograde.
This is the antegrade wire.
Yeah.
This is the antegrade balloon. If I get it back
Slightly withdraw it,
Little back,
slightly.
yeah.
please.
This is the antegrade balloon.
Yeah. That's it. Or
Yeah,
we can do
that's
the integrate
better.
or the retrograde.
कौन सी wire है
It's the
antegrade?
integrate, yeah.
Huh? Which wire do I have
Gaia
antegrade?
3.
Okay.
Can you take just a small antegrade shot and see what is happening around that area?
No. I think if I maneuver the retrograde wire, should I try to get this?
First, you must know the integrated area where you are playing.
I think this looks better.
From this point
Important
it
is
diverts.
the A plane, a little bit areocranial, will tell you probably.
Hmm?
Take different view now because you don't know from where that
Do
angle
we
is
know
changing.
antegrade is okay?
No, doesn't seem to be.
Let's go in some other plane.
Mm. Maybe I do a small test and find out where
No,
my wire.
Not
the
a
question
guide
of a
supply is
guide
not- no,
extension here is
it's
not
not.
helping because you need to establish your antegrade wire first and then dilate.
You don't need sport here. You don't need
Yeah.
to
Antegrade wire, sir.
just need
So the
antegrade
retrograde
injection where you
wire
are
actually is progressing and overlapping.
In
and
this position, I think we should do a balloon inflation. That's what
Move
I
the
think.
balloon little forward,
No,
sir.
first you need to check from
This
other
is-
view also. You
If-
cannot dilate balloon like this situation.
Yeah, but if the other view is good, then you
then
can
only
do
get
it.
Otherwise, not in this situation where you're not sure.
How is the other view? The A plane?
A plane, can you show the A plane, please?
It looks better, sir.
Come
okay.
to the micro and ask.
Yeah, airplane looks better.
You
okay.
need to go cranial, areocranial when you work in the proximal. But it looks good, actually. Yeah, you probably can dilate and make the connection here.
Now,
It
Yeah.
looks very good.
Give an injection now.
So I'm running it, sir.
Just hold on, let me go there
It's okay.
first. Okay, so let us do it. Let's do the balloon now.
Yeah. So this looks very good, and maybe we
Where
go
is
back
my
to the
retrograde
other
wire?
This
plane,
one, retrograde wire, sir.
the
I
B
just
plane
hold it.
again.
The
Yes,
moment
sir.
you deflate,
Yeah,
deflate please.
deflating, sir. Yeah,
Yeah, very
it
good.
entered.
good.
So there we are.
Almost inside.
Yeah,
Inside.
We are already in guide.
Oh,
we are inside the
Good,
guide.
Very good.
very good.
So there it is.
Yeah.
I think that's a great job done.
Great job, sir. I think this
Yeah, but
part of
it's
the
understanding which wire does the right track, and probably
Yeah, that's yeah.
retrograde
Yeah.
wire. I was
Now I
ready up
can. Now I can do it.
Yeah.
इसमें क्या है इस गाइड के अंदर?
सर ये आपके पास आप क्या फॉरवर्ड कर रहे हैं? ओके
I
दिस इज
am
गाया
trying
2 गाया 2
Huh?
गाया 2
No, no. और क्या? ट्रैपिंग बलून?
Trapping है, sir.
तो ट्रैपिंग को हटाओ यहाँ से.
अभी ट्रैप करना होगा ना सर कर्सर फॉरवर्ड
you have two balloons there. You have
Yeah,
chance it's
ये
there
ट्रैपिंग.
actually.
ये ट्रैपिंग है?
ये ट्रैपिंग है
Okay, I'll pull out the trapping. Okay.
ओके अच्छा यू डोंट
No,
वांट
no.
टू
I
ट्रैप द
want
वायर
to trap the wire. I
you,
do
keep
want
the
to
don't
keep
need
the
a
trapping,
trapping
sir.
balloon when you have the balloon there.
Just a sec. Just a sec.
निकाल लो.
Let me advance this first. Let me advance this, then I'll.
So we can trap the retrograde wire and then advance would be better, sir.
Yeah. Which is this the trapping?
This no, we can move it back. So this anti-grade balloon, sir. Yeah, we can trap it.
I
this.
can trap with this
Yeah,
also.
I can trap it. This, okay.
Okay, trap
I'm
it with
trapping,
this. Come on. All right.
Now you
Okay,
can push
trap.
cursor.
Where is the cursor?
Now we can push the cursor, sir.
It is trapped, no?
Yes, sir. Sir, even like left guide, sir. Wait, sir.
Left guide, you pull it back.
Push it, sir.
Keep
So
the
now
left guide
the
unhooked.
Corsair is already in.
Keep the left guide unhooked.
Already in guide.
Okay, it's guide entered, sir.
Near the trapping balloon actually.
So okay, it's entered.
Trapping balloon को पीछे
A
करो.
small trick when
Trapping
people
balloon
have
को पीछे
problems
करो.
and
Left
it's coming back all the way, you can also trap the tip of the Corsair just with 2-3 atmospheres,
ठीक है.
and
Okay.
then you secure the
Yeah.
position.
Okay.
Okay.
Let me see where I am. Where is
Or
my
you get it
Corsair?
further up.
Corsair is all the way in.
Yeah, it's in.
But the
it's
thing,
just at the
the
mouth of
further you
exhale,
go
sir.
in, the longer you have to go back again, and sometimes that's the more difficult part, especially when you have to check the guide.
Where is the Corsair? Yeah.
So it's entering the SAL mouth, sir.
Okay. Okay. So,
Okay. A little
Dr.
more
Goel,
circulation.
we'll
Yeah.
quickly switch to
Circulate,
Apollo.
left
They
right side,
show
left
us
right,
their final result, and then we spend the final few minutes with
Yeah.
you.
Yeah.
Because now the stage is set for externalization and
Yeah.
everything, the main part
So remove this
was
balloon,
nicely demonstrated.
So
So
remove this
we
balloon.
switch to Hyderabad.
Oh.
So Dr. Goel, we are back with you.
Yeah, yeah, yeah. So I am putting RG3 right now.
So you have to move it.
देखो पीछे ना आए ये।
हाँ. एक मिनट चाहिए. It's gone.
रुक जाओ। कहाँ है?
अभी आएगी सर, आप डालिए.
अभी तो वहाँ से निकली नहीं है।
सर निकल गई है सर. It's in my hand.
हैं?
Wire is in my hand, sir.
ओह।
Okay, sir. Push, sir.
इसको खुला है उधर?
Yes, sir.
No wonder it was backing it. Okay,
Okay, it's out, sir.
it's out?
Out.
All right. So we have the RG3 in our hand here.
Artery forceps.
Okay,
Okay, just give me a minute.
all
sir.
right. So now I can withdraw the Corsair. Just put something on this so it doesn't run away. इस पे कुछ लगा दो, torker.
We should show the good pictures and not the chairs.
What are they showing? They're showing the chairs.
Yeah.
Then fluoro दिखाओ
No,
भाई.
but we see you on the
You see me.
You are
that's-
there. Okay.
Yeah, I am very much there. So, okay.
Because the other lab has finished the case.
So where am I? So I am trying to withdraw the Corsair back.
So just a minute, just a minute.
But
So
unhook the
important now,
guide. Yeah, unhook
your
the
guide
guide.
is much too deep. You need to pull back the guide
Guide
into
has
the
gone actually
aorta.
too deep.
Yeah, yeah, I know.
That's
It
very.
has come out, yeah.
Okay,
Okay, sir.
so you're controlling the guide.
It's going in again.
Okay, that's fine.
Good.
Yes, sir.
Maybe
I
a little
need
bit too far even.
इसकी length छोटी क्यों है?
So important to protect the
इसको पकड़ो जरा किसी चीज़ से।
collaterals. Should be a little bit more outside in the PDA, I think. Your Corsair. I would push it forward a little bit.
Length here, actually, that's why.
इसको अंदर करो, इस length को अंदर करो, उधर खींचो, pull it from there so that we have some more length here.
No, the Corsair is coming too
Aram
far
se.
back.
Okay, so that's it.
Ah,
You are trying taking it
It's
out.
coming back.
You should
okay,
push
that's
it
fine,
actually.
that's fine,
Left guide, sir.
that should be fine.
Left guide, sir.
Left guide should be in more.
Okay, perfect.
Okay. Now I need to do a balloon on the right. इसको हटाओ. Remove this.
Yes.
Get me that 2.5 balloon, the same
collateral
balloon.
seem to be uncovered distally.
Hmm?
Collateral seem to be uncovered by Corsair
Yeah,
distally.
Yeah,
the Corsair should
I
go.
think, I think
take
the,
2-3
it's on the
centimeters
distal
forward.
end.
You should put the Corsair 3 centimeters forward or 2 centimeters forward.
That's fine,
Still
I
more.
think.
Okay, better.
Because anyway, there you don't want to stand.
Yeah, that's right. इसको डालना होगा, I can't see. You see, my vision is
So
not so
our
good.
transmission time is probably limited. So it
Yeah,
would be
I
good
think,
to get some
you
IVUS or
ma-
some information.
Uh,
3 to
let
4
me
minutes
just,
left.
I'll just do some balloons so that you have passage for IVUS.
Yeah. So 4
So,
minutes. We
yeah,
stay with
let's
you
see, let's
to
see.
the end of the session.
Okay. Can you fix the wire? Are you fixed? Okay. IVUS ready, please. Oops.
Now close the lesion.
There it
Yeah,
goes.
it's closed.
Actually, there was some calcium there, I knew it.
It's 2.5 balloon.
Yeah, that's a 2.5 balloon. something here, maybe there's some calcium here. IVUS, please.
So I think in summary this was a very good demonstration when retrograde approach is a good early option.
Yeah, you should
Not the
switch
first.
early. I think that's what I did. That's what I think early switching might.
But again, it's shown also importance. You could have left the antegrade wire a little bit deeper initially, because it's always then the good target for the retrograde.
Actually, the antegrade wire I switched. You know, the antegrade wire was not in the right track at all. In the other plane, I don't know whether you saw that. It was just not in the right track. So I was sure now there's no question of parallel wire or ADR. I wasn't even sure whether it's in the architecture of the artery. So that's the reason So, and that's the reason I immediately switched to retrograde.
So we get IVUS information. And
Yeah, I'm just trying to put the IVUS in. इसको डालो यार. ये डलेगा कैसे साला? एक second.
Did you do
Just
the
hold it.
left main with IVUS or without?
The left main was done with IVUS. Left
With-
main is fine. There is no issue.
Yeah?
I can assure you of that because that was done with IVUS
Okay.
and that has been done by me and I know it was perfect. Okay, so now the IVUS is going in. Okay, fix the wire, please. Fix the wire, please.
So any comments from our commentators who would have done something different? So we have 53 seconds left.
Yeah.
Enough
Okay,
for
IVUS pictures, please. Come on and. Yeah, imaging on, please. Show the IVUS picture, please.
We see it.
Okay, so that is in the distal part of the lesion. I think we are, just a sec, I think we need to go a little more distal. We need to go a little, okay, so that's the normal artery. Can
Yeah.
you see that?
Yes.
Its size is about 1,
They
2,
should
3,
show
4.
the angio aside of side by side.
Can we see a LAO angio? Can you show me a angio on this itself? Can we? Pull back start, yeah, pull back start. Start pull back.
Okay.
Actually,
cool.
we are on fiber, so if you want, we can
Yeah.
extend by 2-3 minutes. There's not an issue because we're not on satellite. Okay?
Yeah, I think we should finish this run.
Yeah. So that's a negatively remodeled area of the occlusion, if I'm not wrong, because it's narrow there, and that's the calcium, which did not let me go in.
Yeah, you have
You
a
know.
nice side branch.
Yes.
Probably stays open.
Yes.
Because
And
you
we
are-
are still. Because area of subintimal area hematomas. Yeah.
Yeah, but still it's luminal because
Yeah,
you
it's
have
still
the
luminal.
calcium.
Yes. Yes.
It's
Still luminal. Correct.
It's kind of a dissection within the plaque.
What happened? Sorry? No, no, it's not in the guide. Imaging, it's not in the guide. It's still there. It's still there. The imaging is, just flush it little. Just flush it.
So it's 1, 2, 3,
Yeah.
4 millimeter.
Yeah. Okay, pull back again. You see my catheter is there in the proximal part of the vessel.
Yeah, it's all
And-
true lumen.
Yeah, I think finally when we probably the retrograde wire was in the right plane and I could direct the antegrade wire based on the retrograde wire, and then when I did the balloon I was already intimal.
Yeah.
That's what happened.
So, but
So
it's a
it
big
is-
vessel, 3.5 to 4.
Yeah, yeah.
So I think we can congratulate you. I guess
Yeah,
you will
thank you.
know how to stand. We don't
Yeah, certainly.
need to witness that.
Yeah, okay, great, thank
Very
you.
good.
Well done, well done.
Case.
Thank you.
Thank you very
Thank
much.
you.
Thank you
Yeah.
very much, chairpersons and members of the
Yeah.
expert panel.